Now we're gonna begin. Um, Welcome to everyone. This time we have as a guest Dr. Matthew May. He is an associate professor and director of the Hematopoietic Cell Transplantation and Cellular Therapy Fellowship and co-director of the Lymphoma Fellowship, also at City of Hope. So lots of titles, great guest. We're honored to have you here. We're honored to have you come to Chile, and we hope we can have a nice conversation about Hodgkin's lymphoma.
Thank you so much for the invitation, Dr. Diaz. Really appreciate it.
Great. So let's get into it. So Hodgkin's, we usually get this diagnosis referred to us, sometimes in the diagnosing stage with the lymphadenopathies, but most of the times we get someone referred with a biopsy, and then we go to the staging prognostic process that will lead us to plan a treatment. So any aspects that you do with some kind of perspective related to the first staging and risk stratifications?
Sure. So our usual practice, as I'm sure it is, similar in Latin America and in Chile in particular, is we stage obviously with a PET-CT scan, and that's mainly to establish whether someone has early stage, meaning stage 1 or 2 versus advanced stage 3 or 4. These days in the United States, the management of stage 3, 4 disease in a fit person has basically coalesced entirely around AVD plus brentuximab vedotin. So ever since the Echelon 1 data, well, when it was initially published in, I believe, 2018, when BV was approved frontline in the US, there was some, it was still kind of divided as to whether or not to use that versus ABVD. And, we would sometimes run into trouble with insurance companies. Some of them would even say that, depending on the initial IPS score, whether to use one or the other. But, obviously with the latest 6-year Echelon 1 update, showing overall survival benefit with BV, essentially practices almost switched completely over to brentuximab-based frontline therapy, at least in the United States. So for stage 3, 4 fit, it's relatively straightforward. It's almost one size fits all. Obviously, the discussion is a little bit more nuanced for older patients, but I'm happy to talk about sort of how I think through that too. And so really where I would say there's more diagnostic, or not diagnostic, but sort of dilemma as to sort of how to proceed is early stage patients. Because there's any number of things that you can, the biggest considerations still remain, do you do radiation? Do you not do radiation? And if you don't do radiation, we kind of accept a slightly higher, you kind of expect a slightly higher rate of relapse, but yet maybe you diminish, long-term toxicity, although even then we don't really know for sure, right? Because with the more modern, techniques of radiation and more precise, targeting, it's hard to say what do we don't even really know what the 20-30 year outcomes, as far as secondary toxicities, as far as breast cancer in female patients. So I think that data are a little bit lacking. So I would say that that early stage is actually, from a decision-making standpoint, a little bit trickier. But in that case, we look at the standard prognostic, markers. Although obviously there's a number of different risk stratification schemes for early stage disease. And practically speaking, where I practice at City of Hope, we do our best to put people on clinical trials. So, right now we do have a multi-center trial for early stage disease that randomizes patients, after 2 cycles of ABVD, and for PET negative patients, they just get BV and nivolumab consolidation for 3 cycles, and that's it. So regardless of whether it's bulky, non-bulky, that's it. So no radiation, only 2 of ABVD. So kind of a brave study design. But so again, for advanced stage disease, relatively straightforward. Early stage remains kind of tricky. My general bias is I try to avoid radiation in younger patients, especially younger female patients. If it's really bulky, off protocol, I tend to do more of a Rathel approach, with 6 cycles and, de-escalate after 2 of ABVD. The interim PET is like a Dovo 1 or 2, maybe sometimes, depending on how the patient's doing, maybe we'll stop at 4 of ABVD. But again, it is a tricky, there's no one size fits all for early stage. And I guess one other big practice thing in the United States is that we very rarely do any sort of Baycop-based treatment. It's very uncommon in the US. And one thing we've also seen in patients who get treated, even outside the academic settings, we'll see that even with a positive PET2, even with a positive interim PET, where theoretically, if you go by the book, you're really supposed to escalate. If you actually, and there's been data published on this in terms of real world practice patterns, that actually escalating to Baycop, is not very common. And so, I've seen plenty of patients that, they have a positive PET2 and they just keep getting ABVD, and they, and obviously, the majority of them relapse, and then they get sent to me for transplant. So, but we do, so again, and I know one of the questions you had, raised was, about usage of, Baycop, maybe, or Baycop-like regimens, and those are nearly like non-existent in the US. And again, some of it's biased. There was always a big divide between US and Europe as far as usage of Baycop between America and Germany on it. But there is some truth to it. I mean, there is very, very, very little use of Baycop anywhere, even in one of the arguments you can make in the academic setting, is that, for patients that, that see me and that are treated at City of Hope, for instance, we have access to the trials, we have ready access to transplant, so we can sort of move patients to second line transplant pretty quickly. But that isn't the case for a lot of patients who maybe live farther away and who don't have access to like a transplant center. So, right. A little bit of a long-winded answer. Sorry about that. I think you're sorry. I think you're muted.
I'm so sorry.
No worries.
No, so you make a fair point that the prognostic factors that we use in early stage, they probably precede PET adapted strategies. So there's like we try to mix both, like the early stage unfavorable, or maybe like intermediate risk, if you want to name it differently. But it is difficult to get one answer, and we, at least in Clinic Alemana, we're like doing 2 ABVD PET scan, and then we think. So I heard you said you try to avoid radiotherapy, but most probably European trials, they also affirm that there is a PFS advantage that we are losing with that.
No, for sure.
So are we making that up in the second line, since escalation with Baycop also is not such a common thing there?
Well, I don't know. I mean, right? I suspect. I mean, so historically we probably were, right? Because we've never really been. I mean, how many Baycop versus ABVD trials have there been done, right? I mean, the list is very long, and how many of them have ever truly showed an overall survival benefit in the long term, right? Not really. So I think that's the argument that's always been made, and one of the tricky things and one of the exciting things about Hodgkin, but also what makes it tricky to interpret the data, is that things are moving so quickly, right? I mean, like second line salvage rates, we do a lot better these days, right? When you incorporate PD-1 based, PD-1 blockade in the second line, you get much higher rates of CR. And I mean, this is one of my big areas of research, so I'm happy to talk about that in, next or at some point, today. And it's at least my personal belief, and now there was actually a recent paper that just came out last month in British Journal, suggesting that, PD-1 based salvage may lead to, may result in less post-auto relapse, even independent of the disease response, meaning maybe not, just, like a CR to BB-Nivo may be better than a CR to ICE in the second line, perhaps. And we're working on our own, and we're doing our own analysis on that, and hopefully that data will be out soon too. And I mean, I personally think that that might be the case. And then obviously with PD-1 blockade in the frontline setting, with, I mean, if you look at the NEVAL data or some of the other early stage patients, I mean, or Pembro ABD sequentially, right? Maybe this discussion is all pointless because maybe we just cure everyone, right? So so I think with all the moving parts, it's hard to say, right? Because I mean, we're doing better on the second line. We're certainly doing better in the second line setting now, but at the same time, we're also advancing first line. So I do think the one thing I do think is that I think I mean, I don't think ABVD is going to be, I think it's pretty inevitable that it's going to get replaced. Whether the BV like based combos get to a first, or the PD-1 block combos get to a first, but I don't think it's going to be around forever. But in the meantime, it's harder. I think it is a little harder to justify sort of super intense. Well, I take that back. I should always preface it by, I understand in the United States we come from a certain privileged position where we get all sorts of like we get to use all sorts of like fancy things, like and we have relatively generous insurance coverage, blah blah blah. And I certainly want to be sensitive to the fact that that's not always the situation around the world, right? I mean, in our particular ecosystem, in our context, I think that from the like, as far as the decision, for instance, to use radiation or not, in patients that I personally treat, that are the ones that are that come to see me, they have access to the different trials, they're reliable, they show up. I tend to prioritize meeting slightly like going down on toxicity versus like necessarily like getting everyone cured immediately. But it is a discussion, like it is a very like delicate discussion though. It's not a one size fits all. As an example, we have also we also have a public health system in the U.S. and it's not entirely separated from the private insurance system. I mean, they're kind of linked, and to explain the details would be outside of the scope, but we do have a public system. And there's a lot of patients there who do have trouble following up or have trouble accessing care, or any number of reasons that for which in all honesty, prioritizing cure in the front line is probably very important, right? That a lot of them may not have a chance to to get to second line therapy, or they may not have access to a transplant center. And in those patients, I would definitely argue that prioritizing frontline cure, for instance, appropriate usage of escalated BACOP for advanced stage, or or usage of radiation probably does make sense. So I mean, it's not to say that radiation doesn't have a role. I mean, I would say for me, if it, especially if they fit in to the the Hodgkin 10, the HD10 criteria, so relatively low bulk disease, 2 sites or less, favorable risk, non-bulky, and then if it's like in the neck, to me it's a relative no-brainer to just do 2 ABVD plus 20 grays for patients like that. But when we're really talking about when you're talking about maybe 30 grays to the mediastinum, and they're female, who's under 30 or 40, you start to really get nervous. I mean, at the end of the day, like the breast cancer curves are really scary after 10, 15, 20 years. So.
And I heard you mention you use the rattle approach. Do you use the de-escalation for early unfavorable as well, like 2 ABVD and then the completing 6 ABD with ABD?
I would consider that for patients. So I mean, we have this debate a lot. So for patients with early stage disease. So for instance, I mean, as a example of a patient that a pretty typical patient that I see, right? 30, let's say a 35-year-old woman with let's say non-bulky stage 2, but maybe she has some B symptoms. ESR was like let's say ESR was like 50, or and then you start her on ABVD, and then do you and then the interim PET is Bilbo 3, for instance. So I mean, technically interim metabolic CR, and you're a little bit nervous about doing radiation, but so what would be the right approach to avoid radiation, right? Would you just do 2 more of ABVD, just say ABVD times 4? Would you do or to do raffle. And I don't, we have these discussions all the time, and we don't have a consensus in the department at all about how to do it. And it kind of is up to the individual physician. I mean, I think that's precisely the patient population that we could probably do, better on, because, the bottom line is we know that, you add radiation, relapse rate's going to definitely go, if you do like 4-BBD and radiation, relapse rate's going to be pretty low. If you skip the radiation, yeah, you get less toxicity, but the relapse is just going to be higher. And there isn't a great way around it. Sometimes I'll end up doing a raffle approach for someone like that. Especially when an interim DOVAL is like 3, the patients who were on was the CalGB, I think was 506 before. The one that had the 4-BBD, like the interim DOVAL 3s, the long-term PFS actually was not that great with ABBD times 4. So I get a little bit nervous when it's an interim DOVAL 3, for that. But again, it's that's personal opinion. It's based on a small subset analysis. Definitely should not be like taken as gospel. So
great. And you said like everyone is moving to ABD for advanced stage, and no one is using escalated BIACOP. Is there a space for brentuximab with an adapted regimen for escalated BIACOP, like BR-ECAD or something?
I mean, yeah, like I was at so I mean, I was obviously at the ASH session, and it was HD. Which one was it? Was it where they presented the toxicity, the difference between BIACOP and brentuximab? Was it the 18 or 21? It was one of the German Hodgkin group trials, and I mean, it looks pretty. It does look pretty good. I mean, certainly, adding in brentuximab, switching from switching from procarbazine to dacarbazine, and then adding in brentuximab instead of bleomycin. I mean, certainly the toxicity was better. I don't think they've published the final efficacy outcomes, so I think that was just the toxicity data. I mean, it's a little tricky because I guess you'd have to make the argument, well, do you just kind of I mean, I would say it's a little tricky to escalate to something like that until we at least have some efficacy outcomes showing that they're kind of comparable. I mean, I suspect they are, but there's a little bit of a leap of faith saying that, hey, escalating to brentuximab ECAD is the same as escalating to BIACOP. I mean, they might be, but I don't know. And another tricky thing is from a practical standpoint, because there's so little usage of these regimens in the US, there's just not a lot of practical experience with it, right? I mean, I think I might have given like BIACOP like once in training. I've seen like 1 or 2 patients referred to me that had it in the frontline setting, and that's pretty much it. And I see a lot of Hodgkin patients, and there's just, so I guess also collectively there's just not a lot of experience with the regimen too, I think that at the end of the day, that's part of it, right? When there's not a lot of experience, you just tend not to use it. So
okay, so we move to your field now. Relapse and refractory. So first, before we get there,
sure.
I have like this research question. I told you before, I think, PFS as an outcome.
Mm-hmm.
I have the idea that there's been some debate related to this because Hodgkin's is seen as a curative intention disease. So,
Mm-hmm.
So we're going to treat you and we're going to try to cure you. And in that sense, overall survival, could be the best approach if you want to measure or try to surrogate cure, because cure is going to be very difficult prospectively to measure.
Mm-hmm.
But not everyone gets cured, and we need to assess efficacy anyways. And so I've been thinking about this idea that PFS, it's different, the interpretation in the relapse refractory setting than in the first line. This is going to be very important when we interpret the consolidation and maintenance.
Very much so. I completely agree.
So Well, what do you think about it? PFS
Well,
as an
I mean, I think one
outcome?
thing is that, amidst all, we're obviously, always, I mean, sometimes you just don't know the answer until you like wait a little longer, right? I mean, we're obviously all really impatient people. I mean, none of us are, we're always eager to see what happens next. But, it does bear, I think, keeping in mind that at the end of the day, right? I mean, all these, novel salvage regimens or novel second line regimens, I mean, they weren't like the data on these are not that old, right? I mean, we even think about, for instance, BV monotherapy or sequential BV ice back from, from Memorial Sloan Kettering or, our BV monotherapy salvage or even BV Nivo. I mean, these things were not published that long ago, right? And so I think, so I do think, so obviously it's early, but, and certainly, when you throw in, BV Nivo, just as an example, let's just pick BV Nivo, right? BV Nivo, with its, response rate was, gosh, I think it was like close to 90%. CR rate overall was like, about 2/3, close to 70%. And then post-transplant PFS was pretty good. But I think that, but I think, and then and it gets further diluted, right? Because, these patients go to some of them maybe go to BV, maintenance post or BV consolidation, whatever you want to call it, post auto. And then, that BV Nivo consolidation trial that we published in Lancet Hematology, that was, that's going to dilute results even more. We had a handful of patients on Pembro. We had a Pembro consolidation trial too. I mean, that was, where Philippe Armand was, the main author on that, but, that was going on too. So, any number of reasons where the, perhaps the sort of the elusive question or as to whether or not these patients are actually cured, that is obviously going to get obscured, right? Anytime you give someone effective therapy, you're going to delay the time to the next event, right? And so this is also what, this is also one of the early criticisms of Athera that I think, I mean, obviously the 5-year follow-up for that was I think a very critical publication. But before that, I mean, the question was like, well, I mean, if you're giving BV consolidation to 50% of patients who are cured, and so like if you're cured, and then you just get neuropathy. And if you're not cured, then you're just delaying an inevitable relapse. So what's the point? You're just increasing toxicity for no benefit, just giving BV a progression. But then, what was obviously, what was very striking was that, hey, no, that will actually, 5 years after, the curves are like, they're like parallel. I mean, it's not like the curves never converged, not even close. And so that was really striking. So I think something like that is, I mean, I think that some analysis of that sort will need to be made, I think, to sort of convince people, right? Because right now there's the main question is whether or not these like more effective second line therapy results in a higher rate of cure, right? Because that's ultimately what we want. But there's a lot of moving parts. So the transplant itself, there's not really a lot of innovation, right? Everyone uses Beam. We haven't found anything better than Beam. So okay, fine. But then there's the pre-transplant therapy, and then there's a post-transplant therapy, and both of them are going to obscure the results. And so if you take it all together as like a package deal, which, because I mean, your whole second line therapy consists of your salvage, transplant, and any maintenance. You're going to have to at the end of the day, you're just going to have to wait it out. But I do think, at the end of the day, most transplant, most post-transplant relapses certainly happen within 2 years. Once in a while, you get a later one, but post-auto, most of them will relapse within a couple of years if they're going to relapse. Let's say they get, I mean, even in the worst case, even in the most extended case of maintenance, right? Let's say somebody gets 16 doses of BV, which I've never heard of, but let's say theoretically that happens, right? That's still like, that's just 1 year at most, right? So, so I think that when you're starting to see, 3 years, 4 years, 5 years post-transplant PFS, and the curves are really separating out, I think that tells us mostly what you need to know. I mean, at the end of the day, overall survival is going to be a tricky one because, then you can still keep people alive typically with, any number of tricks, a little bit of radiation here, a little chemo there, a little PD-1 here. You can keep people afloat. But I think what it would take to really convince me is to see like a true, like, a true ongoing, PFS that's like dramatically higher than what we've seen before, right? Because I mean, historically, we know pretty well what to expect from, standard, ICE plus auto or whatever. But I think if you're really seeing these, like, for instance, these like 90, PD-1 plus chemo, now we have, we have two, we have Pembro GVD, we have Nivo ICE, Pembro ICE is, the manuscript's being, under review right now. But they all show very, very similar like CR rates. And so, if we're seeing that, PD-1 plus chemo plus transplant, and you're seeing like, 3-year, 4-year post-transplant survival, far exceeding what we saw with your chemo plus beam combinations, and if you're seeing, significantly higher PFS from the time of initiation of second-line therapy, I think it tells you what you need to know. So I think PFS is okay, but I think it probably needs to get dragged out a little bit longer, because I think ultimately it's a reasonable surrogate. I think we're not quite there yet, right? Because with all these novel combinations, you want to get the data out, you want to, make a splashy publication, blah, blah, blah. And so, we're always reporting it, with like 1 year post-transplant PFS or something, we're like, so it's very early. And certainly 1 year post-transplant is not long enough because you're still like in the middle of maintenance sometimes, or you're just finishing maintenance. But I think in another few years, so I don't think it will be that long from now where I think we'll get some more clarity. And I think it's gonna, and I think it will show that that some of these novel salvage regimens truly are, leading to higher cure rates. I personally think that, but we'll see.
So what's your, if you have out of a clinical trial, what would be your first salvage option to go to transplant?
Well, I mean, it kind of depends what the patient got frontline, right? I mean, if they had no BV, no Nivo, or so no BV, no PD-1 in the frontline setting, and they relapsed late, like let's say, someone with, advanced stage disease, they got ABVD, and then 5 years later they relapse, and it's a relatively small volume relapse. Let's just hypothetically say, I would probably just do BV Nivo. The CR rate to BV Nivo for late relapse was like 90%. And it was actually very similar to PD-1 plus chemo. So I would just do BV Nivo plus transplant and then be done with it. I mean, PD-1 plus chemo is, seems to be kind of the new, obviously it's kind of the big, kind of new big gun that, that we're using in this setting. And I think one thing that's been striking is that, whether or not someone has primary refractory versus late relapse or whatever, that it seems to work about the same. So we saw that both in Pembro GVD. We've also seen that in our own Nivo ICE data from City of Hope, that it doesn't seem to matter, that even sort of more unfavorable disease biology as far as, primary refractory disease, like the results are very similar. But whereas at BV Nivo, it seemed that primary refractory patients, again, it was a subset analysis, but it was split pretty evenly between primary refractory and later relapse. And there was a very big difference in CR rates. It was like 90 versus 50% in BV Nivo. So late relapse, no BV, no PD-1, I would do BV Nivo. Late relapse, if they had frontline BV, I would probably just do PD-1 plus chemo still. You could make the argument to just do Nivo monotherapy and to add chemo later, kind of like how our that was actually the original paper. But I think it is hard to ignore kind of the evidence, or it's kind of like the only study that really tackled it that way, right? All the other papers, there was between Nivo, between Pembro GVD, between Pembro ICE from University of Washington, there's a tislelizumab, GEMOX paper from China that's coming out soon too. It's between all of those studies, and sort of ours being the only one where we did PD-1 by itself, I think there's probably a role for it, but the numbers are kind of small. And one thing one regret I have, and one thing that I would still really like to explore more is, which patients can get by with PD-1 blockade by itself, without, PD-1 blockade by itself, without chemo, and then bridge directly with a transplant. I don't think we ever really answered that question. I think one thing that we honestly, I'm not sure we even expected it. Is I wasn't sure that any of us expected the outcomes to be as good as they were. I mean, the 70% CR rate was more than I think anyone thought when we put together the trial. So yeah, so I mean, I think if someone who's had prior BB of any sort but no PD-1, I would just say PD-1 plus chemo for everyone, and then transplant, because I don't really know who is appropriate, who would appropriately not get chemo. And then the other issue, even though yeah, as spoiled as we are in the US, we don't have unlimited resources, and 6 extra doses of Nivo does cost a lot of money, right? Compared to just we just do Nivo ICE or Pembro GBD, you get like 1 or 2, 2 or 3 doses of PD-1 blockade versus like 6 doses up front, right? Which costs like 10 times as much as the rest of the chemo. So that's why for a number of reasons, I think off protocol, again, BB experienced patients, I would just do PD-1 plus chemo to get the transplant, yeah.
So Nivo or Pembro?
For patients being treated at City of Hope, we tend to just do Nivo ICE. And I don't personally, I'm not in the camp that believes that there's any difference between Nivo and Pembro. I don't think there's really any difference between the two. But I've given Pembro GBD before, so I'm not, so I can say I've played both sides. But Pembro GBD, definitely more mucositis. It's yet more anthracycline exposure, and then you're going to blast this person with beam after that, and so I just think from an organ toxicity standpoint, I would prefer Nivo ICE overall. And again, I've done obviously treated many patients with Nivo ICE, and I think overall it's probably a hair easier, like physically, than the Pembro GBD from what I've seen. And again, I really do place significant value on trying to minimize further anthracycline exposure. A lot of these patients had 6 cycles of ABVD up front, so 300 milligrams per meter squared, and then they got radiation to the chest. So I mean, these are patients that, like, if we can avoid more cardiotoxicity, it's probably a good thing.
Great. And after that, transplant and then maintenance?
Well, so this is a great question. So it's funny, if you look at patients that we treat at City of Hope, and so the majority of Hodgkin are treated by Alex Herrera, and he does most, he and I do most of the Hodgkin here. I would bet that our patients get less maintenance overall than patients elsewhere. And there's probably, I would bet, I'm not sure about this. I think one thing that both of us are not, I mean, neither one of us are, really twist people's arms, so to speak, to try to force them to get maintenance. We do present the data. We do present the fact that, yes, there's a, about, PFS benefit, and, we go through the Athera stuff. But I mean, one thing that came out in the Athera, and again, I understand this is a subset analysis, so I'm not saying that this is, I'm not saying this is the final word, but if you looked at Athera, really the patients who only had one high risk feature derived actually 0 benefit, right? There was no benefit in that subgroup with only one risk factor. And so as an example, let's say a patient, relapses, within a year, let's say, 8 months after finishing ABVD, but they have it's purely in the lymph nodes, no extranodal disease, they don't have any B symptoms, they get a nice CR going into auto. Let's say they get PD-1 plus chemo, go to auto. I mean, so first of all, like that's a lot of these, so I mean, that's a pretty common, scenario. And I'm not really convinced that BV maintenance does anything for those patients at all, since they only have one risk factor. And the other thing that I think is that, remember, Athera, the benefit, the 5-year benefit, the 5-year PFS was like, what, 59 versus 41%, but remember, but it's predicated on like the 5-year PFS being like in the 40% range for the high risk group, right, without maintenance, which I would frankly be very shocked. And again, I can't prove this right now, but I would be shocked if the 5-year PFS without maintenance with PD-1 plus chemo pre-transplant followed by transplant, I'd be shocked if it's 40%. I think it's significantly higher. And then so the question is, well, how much more is BB going to help above that? It'll probably help a little bit, right? Because at the end of the day, we know that BB obviously is a very effective agent by itself, and BB does probably cure a few patients by itself, right? You're probably maybe 10%, give or take. I mean, that 10% was kind of the figure that was tossed out in that 2016 paper by Rob Chen, looking at 5-year outcomes after BB monotherapy. So about 10% with patients with who got BB by itself never progressed, and we've all seen a few. I'm sure you have some in your clinic. I have some in my clinic. They got BB like 5-6 years ago and never came back, right? But it's small, but so there is a curative signal with BB as well. So what I usually do is I present patients sort of I give them the context of Athera. It's pretty rare that I have, like, I would say the overwhelming majority of my patients get some sort of PD-1 based salvage prior to transplant. So if they have only one risk factor and they got that, I tell them, look, officially the guidelines say maintenance, but no real benefit in the subset analysis. There's, I present them all the data. Some of them still choose to get it. I mean, some of them are like, whatever you could possibly do to maybe decrease the chance of relapse, I don't care. I'll show up every 3 weeks. I'll get neuropathy. I'll get neutropenia. I don't care. Just do it. Then what we'll do is we'll do it, and then we'll see how they feel. A lot of them are like, I just went through so much just to get here. I'm tired. I want to get back to my life. I don't want to do this. And then that's fine. And then we leave it alone. For the higher risk patients, like have really bad extranodal disease at the time of relapse, they're primary refractory, all this stuff. Then we talk more seriously about, hey, there's, this is probably the group where if there is a benefit, I mean, this is really the group that the lion's share of the benefit is to someone like you. And we go through it. But I'm very clear that the biggest drawback behind consolidation is the fact that the patient already might be cured, but you don't know. You can only find out that they relapse, right? Otherwise, you'll never really know. And so I think that I always present as a patient as in like, you might be cured, you might not, we don't really know, but overall, if you take 100 patients like it will, it will probably decrease the chance that it comes back by, X amount, but even that X amount, we don't really know, especially with these PD-1 based salvage, I don't know. I strongly suspect that both the absolute and the relative, difference is not going to be that high. I can't prove it, but we go through all that, and some patients choose to proceed to it, some patients don't. But either way, I never push that hard because a lot of them have been through a lot just to get there, and and a lot of them are just absolutely exhausted. BB maintenance, you're supposed to start between 30 to 60 days post auto, right? I mean, that's the way Athera was designed. So so we talk about it, and I would say that the majority of our patients ultimately choose elect not to go on maintenance, who would be technically eligible by Athera. So.
And I think you were trying to shorten the length of that, adding anti-PD-1.
Yeah, so that was the idea, to try to do BB-Nivo. And the idea was that, hey, in Athera, like, no one can get to 16 cycles. I mean, I have no idea how they actually studied it. I have no idea how they, like the 16 doses is kind of ridiculous. And so what about cutting it in half and adding PD-1, right? Because there was Athera data, and then there was the Pembro maintenance, by itself, and then so what about just kind of cutting it in half and just doing BB-Nivo times 8 rather than 16? So that was the concept. And again, I mean, their early efficacy results looked pretty good, but the toxicity was substantial. I mean, it was not trivial. We had a couple of patients that got really, really sick from PD-1 mediated toxicity. A few patients got admitted to the hospital. Whether that's just your run-of-the-mill, PD-1 stuff that can happen, or whether it has something to do with the fact that their immune system is still, they're kind of reconstituting your immune system early, and then you slam them with PD-1. Maybe, maybe that's a little bit too early to give it. Not really sure. But it was, but I would just say that the toxicity was still substantial. And we had a number of patients that had to either stop one or the other, or both. and even with 8 doses, I mean, we still had a lot of patients that had that after 4, 5, 6 doses of BV, they're like, I'm done. No, I don't want any more neuropathy. And so yeah, I don't know, where that will eventually end up as far as, whether there's going to be any further study of that regimen. Again, having treated a number of patients on that trial, I would say that, yeah, we got most patients through it, but there were the toxicity was also not trivial, just sort of seeing how, people felt. And, again, we had a number of, the PD-1 mediated toxicity, like we had a few pretty rough cases, so.
Cool. So what after a second relapse? Well, after that,
right.
What do we have?
So this is a really important question, and obviously, hopefully this will be, as we're incorporating novel agents in earlier lines of therapy, this will become less of a question, as we get fewer and fewer relapses. But ultimately, at the end of the day, you'll still have patients who just have the worst of the worst disease biology, right? It happens. We all see it. And so the question that comes up a lot, and again, this is incredibly context dependent. I think this is a really important question, is whether or not, so let's say someone, who's BV, Nivo, BV plus PD-1 experienced, autologous transplant experienced, maybe leave it blank whether they're truly refractory or just been treated before, but with BV and let's say Nivo, but they may or may not be actually refractory to these agents. And they've relapsed post-auto. And then the question is where to go next. I think that it is true that at the end of the day, there's probably not a great way to cure someone like this without allo. And so I'm definitely, so, you'll see a lot of different attitudes about allo and Hodgkin. Some people absolutely hate allo and Hodgkin. Some people might be a little bit too happy about doing it in Hodgkin. At City of Hope, those of us who've been there for a few years, we were all trained on allo, so we still do our own allos. And so we definitely feel comfortable doing it. And I certainly think there's a very important place for allo, especially now with post-transplant Cy, where, your post-allo outcomes are much better than they used to be, right? Even if you looked at 5, 6 years ago, or, even, for instance, CIBMTR, there was a reduced intensity allo, analysis published a couple of years ago, and the results weren't that good, right? I mean, 5-year PFS, you're looking 30, 40%, 40% bad chronic GVHD, 20% TRM. I mean, it's definitely not amazing, right? I mean, if you're out of other options, okay, but it's, not super encouraging. But, the chronic GVHD, rate is, with PT-Cy, we're down to 20-ish%, with the relapse rate, from 40, now we're probably also in the 20-25% range. So, outcomes have really gotten a lot better. So, it's not perfect, but allo certainly works. And so I think, so this matters as far as sort of what kind of access to trials and what access to therapies you have, right? I'll give you an example. At City of Hope, for instance, we have tried our best to have at least a couple of trials available at any time, specifically for PD-1 refractory patients. So previously we had a trial of Pembro plus Vorinostat, and that was initially for patients who had a prior response to PD-1, but then we actually amended it to make it specifically for PD-1 refractory. And we found out that the response rate to PD-1 refractory, not just experienced, but refractory, was 60%. Duration of response was like a year. So, were we curing those patients? No, we weren't. But there was something there that we showed that we could at least in part temporarily reverse PD-1 resistance, acquired PD-1 resistance. And so I think our general, so I guess the general thought process is this, like if you really think that the patient has one, that the patient's basically just gonna blow through everything, you have one shot to get them to get a response, then yeah, it makes sense, try to, get your best response and go to allo as soon as possible. I think that's fair. I think at City of Hope, we have, because of, the number of trials we have and, the fact that, the response rates are actually pretty high, we've tended to kind of go around on a few trials. And well, I mean, we'll do the donor search, we'll do the HLA typing, we'll prep them for potential allo. But, you know, at the end of the day, like we, you know, usually you can still pull out some regimen that will get a response, right? You know, whether it's some bendamustine-based therapy, you know, sometimes we've been pulling out, you know, Pembro GBD or, you know, Pembro or PD-1 plus, you know, some other novel chemo at the end, you know, but, you know, it's pretty rare that you throw something like that and you can't get a response. So I guess that, you know, we have, I don't know, I should say, I have maybe a little bit less concern than some other people do, rightly or wrongly, that I can't get a response from a patient that's sufficiently deep to permit us to go to allo. I think that we can usually do that. And so I'm a little bit more comfortable, perhaps, you know, playing around with a few different things. You know, for instance, you know, we had the Pembro LAG-3 trial. You know, right now we have a Pembro, you know, TIM-3 bispecific, you know, the Pembro Barinostat trial. I actually have a you know, IIT with nivolumab and oral azacitidine, you know, and then actually the, you know, also for PD-1 refractory, you know, the response rates, you know, the large majority of patients have responded as well. And so, you know, we usually try to bounce people around on some of these trials first. And I mean, it gives us time to get a good donor as well, to sort of figure out what our options are. And then, you know, because I mean, to get someone to actual allo, you know, you still have, you know, various combinations of BV, PD-1, chemo. We've had a few patients actually where, you know, also we've seen it a couple times now where, you know, they've gotten BV, they've gotten Nivo separately, they're refractory to both. And, you know, we didn't really think that there's that much synergy between the two. But we've had a few patients actually have a very nice response to the combination despite being refractory to both. We didn't think that would be the case, but we've seen it now a couple of times. You know, and then there's, you know, and then you know, University of Chicago published on lenalidomide, and, you know, and I think it was, yeah, temsirolimus, lenalidomide with, you know, 2/3, I think, response rate in Hodgkin. A lot of them bridged to allo. So I think there's enough ways, enough tricks up our sleeves that I think I'm comfortable that we can usually get them to allo. So I try to, so the way I frame it is like, you know, patients, they're, you know, they read, they're intelligent. I mean, a lot of them will ask, you know, is there any other curative option besides allo? And I told them, you know, generally no. But that we can keep the disease under control for a while, sometimes many, many years like this. And I personally don't feel usually a huge urgency to go straight to allo, you know. But again, you know, someone who says that, oh, you know, after PD-1, after BV, you should just, you know, throw everything you have and quickly get them to allo. That's not wrong. You know, that's not a wrong approach. And, you know, patients mainly with really, you know, like aggressive disease, or they really feel like they don't want to try one of the other trials, they just want to go straight to there. That's okay. It's not wrong, but we're pretty comfortable in not going directly.
As a great academic center, I see a lot of your answers are clinical trial. What is the proportion of randomized versus single arm trials that you get?
That's a wonderful question. We don't do as many randomized. And well, we do some, but, you know, so one of the things is, you know, as at an academic center, you know, with a lot of, you know, young investigators who, you know, they want to make their mark on this world, they want to lead something, you know, whatever, right? So, so a lot of our trials are going to be with novel agents or novel combinations or some investigator-initiated trial where, you know, you're doing a novel approach to something. And so these are almost always going to be single arm, right? I mean, you might, you know, at most you might get to a phase 2 with like a randomized portion, but we don't have, but, you know, so I would say the large majority of our trials are, you know, phase 1 with a, you know, expansion, you know, with, you know, a phase 1/2 or phase 1B trial with a planned, you know, with a planned phase 2, you know, at the DLT or whatever, or at the MTD or whatever, or phase 2 with a safety lead-in, you know, and that's a way for us to kind of explore, you know, either novel medications or novel combinations or novel approaches. You know, do we participate in phase 3s? We do. You know, for instance, I mean, we participated in Echelon-1, we participated in Polarix. I mean, these are all, you know, big trials that we also opened at our center. Yeah, we participated in, you know, R-CHOP, you know, Tafelen. I mean, so, but I think and then it goes without saying that, you know, that Dr. Herrera is he's the, you know, national PI for, you know, the SWOG trial. So, you know, so AAVD versus AVD-Nivo, he's the national PI. So we're leading that out of City of Hope, which is already, by the way, totally accrued. So hopefully we'll get some readout in another year or two. Yeah, fully accrued. Over 1,000 patients accrued by last year. So, but I think that, so aside, so there's kind of these larger cooperative group trials that, you know, if you want to be a part of SWOG and you're a member of these cooperative groups, you know, you kind of have to be a good colleague. You can't like not open them, right? So we do our best to participate, you know, and you know, the issue is that at the end of the day, you know, everyone's busy. I mean, everyone, everyone who works in this field is incredibly busy. Our research team is also very stretched. And so we also have to think about it from an institutional standpoint that, you know, if we are investing a certain amount of resources in a trial, what does the institution get back, right? Do we get like, you know, because, you know, if you get a first author or a senior author paper, that looks great for the institution, right? If it leads to some more grant money, that's great for the institution. But, you know, if your name doesn't even get on there, like, you know, if you do a phase 3, you pay, you know, your center like hires CRC, you know, and then the reimbursement for the trial doesn't even cover the CRC and then the nurse salary, and then they're late in reimbursing you and your name doesn't get on the paper and you contributed like 2 patients out of 1,000, like, you know, what have you really contributed? And so I think those, and it's not to say that those trials are any worse, they're not. I mean, they're very important trials, but I think also those trials are also easier to run. And so what we usually do is we prefer to run trials that are a little bit trickier logistically, that are more, you know, that are a little bit more innovative, or they're testing like a little bit of a newer concept, they're pushing the envelope, as opposed to kind of the phase 3 confirmatory trials, you know. And again, because I mean, because those trials are perfectly suited to run in a more community setting. They don't quite need as many resources. They're a little bit more straightforward. And there's not a lot of academic credit for it. Whereas, you know, for us as, you know, as academicians, or, you know, as people who try to make our names in the field, there is more to gain from an institutional standpoint. And it also provides access to you know, earlier access to drugs, right? I mean, we had access to CAR T cells. I mean, you know, we were using mosunetuzumab in 2015, right? So I mean, you know, we have access to these drugs like far before, you know, before they're commercially available. And so that's the other benefit. So yeah, large majority are early phase non-randomized. We have a few randomized early phase, you know, that we design. And beyond that, the larger phase 3, if they're a cooperative group, so basically not pharma run, we open those. But the pharma, you know, a pharmaceutical company sponsored large, you know, phase 3, we open very few of those.
We got sidetracked for the research enthusiasm.
Yes, sorry. That was a good question, but no, I felt like that deserved a proper answer. So
yeah, great. So to keep the time respectful, are we getting any close to a CAR T cell therapy in Hodgkin's lymphoma?
We were, and not really anymore. So I don't know if I'm officially allowed to, you know, well, I don't know. I think it's the trial, they've already mentioned that, I mean, they've already sent letters to all the centers. You know, as I'm sure you've seen the data, right? I mean, you know, there's a paper in JCO from the phase 1 CD30 CAR from Baylor. They ran the JCO paper was from a joint, was run out of was a trial run at Baylor and University of North Carolina together. You know, response rate was like 55, 60%, 1 year PFS 45%, no toxicity, looked great, right? And so Tessa Therapeutics, you know, which was the commercial company that ran this, that had the rights to this. So they ran a pivotal phase 2 trial, and hopefully to get regulatory approval. But unfortunately, you know, the early results were not as good as they hoped. And so, you know, they've kind of explored a couple other avenues for this, but ultimately the company is not moving forward with the autologous CD30 CAR. And so but you know, there were promising data. It's very early, but there was an allo CAR. So they're not the same as the ASM13NK, but there was another allo CD30 CAR out of Baylor that was presented at ASH. And again, I mean, it's very early, but that may be promising. I think the thing is though that you know, at the end of the day, you know, at the end of the day, like, you know, I think, you know, I'm not sure that any of these things will be, well, actually, we'll, at the end of the day, I think there is a role for CD30 CAR, but it's probably going to be someone else that has to make it. And I mean, the other obviously big, the big splash was, was with the, AFM, AFM13 complex to NK, umbilical NK cells. And we've actually referred patients. We've actually have 2 patients from City of Hope that we referred specifically to MD Anderson to get treated on that. And the results are really, they're fantastic, but it's not clear that they're actually curative. I mean, the 6-month PFS was like, over 50%, but if you look at the curves a little bit farther out, they just keep dropping. So, so if they're not curative, then again, the question is sort of where will they sort of fit in? Are they, is it just as a standalone? Is it going to be as a bridge to allogeneic transplant, perhaps? I don't know, but I think that one, unfortunately, with this setback in the autologous CD30 CAR, the AFM13NK is probably farther along in development at this point. Because again, I mean, I don't know what's going to happen with that CAR product. I mean, the company's not moving forward with it. So I was the PI at City of Hope for that trial. So so that's insider information. I hope they don't get it for this, but yeah.
Okay.
Yeah.
So Dr. May, it's been a pleasure. I think we are right on time. And we will be very happy to have you here in Chile and to discuss Hodgkin lymphoma and every other lymphoma at Lymphoma Experience.
Sure. Again, I'm really honored that that I'm invited. Always happy to reach out, or I'm always happy to make new collaborations. Anyone with sort of any ideas or questions or anything, can always reach out to me. So I'm always happy to talk by email. So.
And maybe we will listen to you speak Spanish.
Yeah, I'll try. I don't know. I'm thinking about it. I feel very. I mean, I understand everything you said perfectly fine, but I'm always a little bit nervous about speaking it in an academic setting. So we'll see if I have a little bit more courage when I get to Chile.
With some wine, we can fix that.
Yeah, with a little bit of wine, maybe it'll loosen my tongue up a little bit. So.
Okay, thanks a lot. Gracias a todos por venir y we'll see each other here in Viña del Mar.
All right, well, take care.
Take care.
All right.
Bye.